There are certain ways we have been doing things all our life, and then there are alternative perspectives. At Spill the Tea, we spill those alternatives or unconventional ideas with our awesome guests about their stories of challenging the conventional and their journey to bring a significant difference to their communities. Welcome to our 30th episode, and I'm BP, your host today. Now, before we begin, make sure you subscribe to our podcast on your favorite platform so that you get notified for every new episode. And if you enjoy, do give us a 5-star rating and do share this podcast with your communities. We have an absolute inspiring story today, and maybe when you click to tune into this episode, you may have wondered about the topic. It sounds like a slap on the face where the world is sinking due to the massive misuse of plastic, and we are talking about saving lives. Yes, there's a catch. And it's simple but genuine intention, probably a makeshift but now proven and adoptive measure to save infants and their lives using plastic bottles. And to share this story, we have our amazing guest from Bangladesh, Dr. Mohammad Jobayer Chisti. Dr. Chisti, how are you doing?
Thank you, baby. I'm good. It is really great, inspiring introduction. Thank you.
Yes. And before I pass it on to you, I wanted to tell our listeners a brief about how I know you and what inspired me, Dr. Chisti.
Please.
So, okay, this is to our listeners. If anybody out there Google these few words, plastic shampoo bottle saving lives, the first results you will get, and that's what I get. You will get host of videos and BBC articles from Global Citizen, and many other showcasing this phenomenal invention. I would say it that way. And Dr. Chisti, I knew about you through one of the Global Citizen article, and that's how I found you and I reached you. Now, it's an honor, and I should tell this. It's an honor. We are recording this episode with you. And though I come to how you did what you did, let me pass on the mic to you. Please tell our listeners a brief about yourself and anything fun about you.
Thank you, baby. Actually, there is nothing lot more remaining to tell about me that you have you've already told everything. Yeah. I'm just Dr. Mohammad Jobayer Chisti. Have been working in International Center for Diarrheal Disease Research in Bangladesh. And this is a research organization, but it has a small hospital where I'm also doing the service. Right. And on the top of that, I'm doing the research. And I'm proud of that I have been working here, because if I do not work here, I might not have the opportunity to have this invention.
Wow, awesome. Dr. Chisti will talk about this invention. I won't call it little, because we are talking about pneumonia here, and for our listeners, people already know this, that pneumonia affects the lungs after infections either from bacteria or some viruses, which we have seen very recently. However, in a nutshell, it reduces the ability of the lungs to take in oxygen, and we are talking about infants. Now, normally hospitals use ventilators to attend this problem, to cater to this problem. My question to you, and that's my first question, Dr. Chisti, about your invention. How and when did this idea struck you?
Actually, it is a long time ago when I have just completed my graduation, that is MBBS, in one of the public hospitals in Bangladesh called Sylhet M.A.G. Usmani Medical College Hospital. And when I started my first night as an intern in the pediatrics department, there are a lot of kids came with CV and pneumonia. And at least, as far as I remember, 3 kids died of a severe form of pneumonia. And at that time, the available drugs, the available support, we have provided everything, whatever that need. Although I was the intern at that time, I had my senior colleagues, that is, but I didn't find anything that can save those 3 kids. This is what struck me, that I need to do something to minimize the deaths. But trust me, at that time, I didn't know what I should do.
And Dr. Chisti, it all started when you joined this hospital as an intern. Now, definitely, I mean, see, and you know this in your field, we have many fabulous doctors around the world in various countries who are doing fabulous job in saving children, saving people. And I mean, it's really commendable that you took on to this research, found this idea, and you joined, I would say, joined your profession with a purpose, to save infants. So tell us about this technique, or I mean, let me call it as a technology now. And is it in trial or being adopted anywhere else?
Thank you, Vivi. And actually, as I have told that since my intern, then I was searching for an opportunity where I can do this. Because you know that especially in our country, in the profession of MBBS during when we are student or post MBBS, we didn't have ample of opportunity to have the research. So I required an institution where I can do this. In Bangladesh, there was no many. So ICDDR B is a single organization in Bangladesh who used to do very robust research. Mm-hmm. And I was lucky enough that I have told that I had the chance to be here. And then I have searched for these things. And I was lucky enough, then I got the opportunity to study my child health training as well as research in the Royal Children's Hospital, Melbourne. And at that time, I have seen that Bubble CPAP, it is nothing new. It is the fancy Bubble CPAP that I saw in that hospital. Then I dreamed that if I can modify this in a simplified form by only taking the mechanism, then whether it can do anything. So I discussed with my supervisor there that I didn't come here to teach to learn the fancy things, but I went to learn here how the technology can be simplified in our setup. During my 2 years study there that I used to learn. And after my return in 2010 in ICDDR B, I translated this after seeing this. And at that time, I should have met one of my senior colleagues, Dr. Jonathan Harvey Smith from the Great Ormond Street Hospital, who was the consultant and ICU lead at the time. So then I told him, and he actually motivated me that whatever you have in your setting, you should use this to do. And I discussed with him, and with the help of him, I found this discarded plastic bottle, which remains in our ward. And we told that by pouring with water, we can produce the bubble seen in the fancy machine, which is also costly, which is around $3,000, $4,000 or $5,000 like that. But then when I learned that this is the mechanism that if we can produce the bubble in a plastic bottle or in any bottle that gives us the back pressure to the lung, then it may work. That is the exact thing that I have done. That I have used the conventional WHO nasal prong, which is used to be used in case of WHO recommended low flow oxygen. And with that, I have just added part of the discarded saline set. And after pouring the plastic bottle with water, I have inserted the distal end of that device into the water. When patient, after taking oxygen, exhales the air, that air passes through that water-filled plastic bottle, and that produces bubble. That bubble used to produce as against a gradient. That gradient gives the back pressure. And by that simple way, we tried for a few patients, and we have found this is good. And then I told my supervisor. Then the story starts.
And Dr. Chisti, as you mentioned, the conventional methods recommended in the doctor fraternity, in the medical fraternity, and WHO recognized, and the discarded distilled bottles which you had. So everything was in front of you. You just
Yeah,
brought
yeah.
everything together and,
Yeah.
created this.
Those
So
were just available
yeah,
that we were not using before, nothing
right.
new.
Yeah,
As you know, that bubble CPAP is not also new.
right.
In 1971, Professor John Gregory used that fancy bubble CPAP in premature newborn who had the acute respiratory distress syndrome. This acute respiratory distress syndrome and pneumonia is not the same thing. The
Yeah,
pathology is
yeah,
totally different.
right.
So we thought that just have a try whether it works or not. Because in acute respiratory distress syndrome, there is lack of surfactant cell, which used to responsible to maintain the surface tension in lung.
Yeah.
And if it is lack, a lung tends to collapse. And bubble CPAP
Wow.
used to reduce this used to prevent this collapse. But
Right.
in pneumonia, this is not the case. So we
Yeah.
thought that whether it would work or not. Just we have tried with this very simple thing for few patients, and we have found the enormous results. Then if we have that you wanted to know the trial, then we have
Right.
started the randomized trial in actually 2011 to 2013, which
Okay.
led my PhD also.
Okay.
And after the completion of the trial, it has been found that that very simple, innovative, very low cost, ultra low cost bubble CPAP was associated with 75% reduction of mortality compared
Wow.
to the WHO standard one.
That's enormous. And
then,
yeah.
it was published in the Lancet, as well as our hospital
Yes.
adopted this as the part of the standard of care now. Yeah.
Fantastic. So what do you call this technology of yours? I mean, do you have a separate name for this technique of what you're doing with plastic bottles? Do you have a separate name for this, or it's the medical terminology?
No, it is the same thing. There is the bubble CPAP. And
Okay.
it is just every country used to have this name that is called the locally made bubble CPAP. Just we tell as the locally made bubble CPAP, nothing else.
Okay. Okay.
And,
okay.
And you have seen that in some publication, they showed our one as a shampoo bottle.
Yes. Yes. I read that. I read that.
CPAP.
Right.
Yeah.
So is that also true? Like, you have used shampoo bottles as well?
Yeah. The
Okay.
initial, the success that the success story they started, it was the shampoo bottle.
Okay. That's the name of our episode, Plastic Saving Lives, that you can really repurpose something to save lives. And that's what you are doing. So coming back to your research, Dr. Chisti, it took you almost 20 years to come up with this solution. I mean, it started way back when you did your internship, and that night when unfortunately you saw 3 infants passed away. Probably that's when you had this urge to do something and really save lives in an economical, in an affordable way. My question is, at any point in these last 2 decades, did you feel or think this is not going to work? And if that happened with you, what kept you motivated in those times?
Yeah, this is a long story, but I want to make it short.
Yes.
Allow me 2 minutes. Yeah, this is the thing that I told you that at that time I didn't have any idea what I should do. So the only thing I learned that at least I have to be a pediatrician, otherwise it will not be possible. Then on that way, I was trained in pediatrics from, at that time, it is called Institute of Postgraduate Medicine and Research. Now it has been named as the Sheikh Mujib Medical University, Bangabandhu Sheikh Mujib Medical University. So it is the highest medical institution in our country. So after having the training, I had an opportunity to join in ICDDR B. So straight away, I actually searched what I should do. So I was struggling for the initial days that I need to do, especially what kind of focus I need to require. I didn't know for the initial few years that I was just only searching. I need something that I need to do to reduce the deaths in these children. So there are a lot of things. By this time, WHO identified that there is malnutrition is one of the culprit to have the death in pneumonia. So I initially started working in malnutrition. And when I started my master's training, so I focused on malnutrition. I thought that if I can reduce the incidence of malnutrition, then the mortality can be reduced.
Right.
So I have identified a few areas, but still I have seen that a lot of kids still dying with even without malnutrition. So I found that oxygen is the issue. There are a lot of children was dying, even though patient was getting WHO standard oxygen, WHO standard antibiotic, and other routine cares. Then it struck my mind that yes, I'm doing some right things, but I'm not doing the exact right things, which is the single most important thing probably are responsible for that. Then we have found that in a systematic review that children with pneumonia who used to have hypoxemia, that is the lack of oxygen, and if they don't have the hypoxemia, death rate was enormously higher, 5 to 6 times more those who had hypoxemia compared to those who didn't have hypoxemia. Then my focus was there. So I need to find something to treat those hypoxemia. But as WHO already recommended that for hypoxemia, we should use WHO recommended oxygen. Then I thought that we are already using this. I need better than this. Then I searched for that, and I have found that ventilator that you have already told that life support things, and ventilator associated, there is continuous positive airway pressure. It is called CPAP.
Right, CPAP, yeah.
Yes, as it is high costly, as well as it needs highly trained study
technicians,
personnel like nurses as well as physicians. Even though it is available in some hospitals in developing countries, they cannot maintain the proper hygiene, and as well as this is why hospital acquired pneumonia and other infection is so high. So I thought that this should not be the part of my choice. Then I thought that what are the other things very cheap or alternate non-invasive procedure. Then I found that Bubble CPAP that Professor John Gregory used in 1971 in acute respiratory distress syndrome. And another one is called high flow nasal cannula oxygen therapy. It is very popular in Western countries, especially in called bronchiolitis. It is almost near to pneumonia. So then I thought that, yes, I need to do something. Then by this time, I had the scholarship to study there. So I thought that this might work. Then I searched for that in where it is used. Then I had some training in the ICU there. So I found there. So at that time, what I have already told that I discussed with my supervisor, Professor Trevor Duke, that whether it can be used in a simplified form. And he actually encouraged me. And Professor Trevor Duke, I should say that he is one of the pioneer supervisor for me, who actually had great motivation for me. He also works in other developing countries like Papua New Guinea. So when I returned to my country, I have also told that Dr. Jonathan Harvey Smith also helped me. And when I found this, and I have started this trial, but this is the initial struggle. But later struggle, when I have published this, it has been part of the standard of care in this hospital. So it is, I need to take it out from this hospital to other parts of
other hospitals and other countries,
and also other developing countries. And it was not so easy. And after our trial, there was another trial done in Ghana, and that was not only pneumonia, but it is on Bubble CPAP, and this is any respiratory difficulty. And they have also found it somewhat effective, but my trial was up to under 5 children, but they have found it is more effective in children under 1 year of age.
So infants,
infants mainly. And then there was another trial which was done in Malawi, but they didn't follow our design. They because in our design we have shown that needs monitoring, although it is a simple thing. But in the Malawi trial, they didn't have the supervision of the physician. They only had the nurses. So in that trial, they most probably missed the
certain steps, or
those children who were excluded from our trial because it is a very simple thing. It is not the ventilator. It works as ventilator, but it is not the substitute of ventilator. There are certain things we need to consider. Because if a child do not have the effort of respiration, if in that case it cannot be used, because a child need to have the effort to take the oxygen inside the lung. So if they don't have that
capacity,
effort,
you mean?
Yes, that capacity.
Natural capacity.
Then yes, they need to have at least some capacity to have to take the respiration. So in Ghana trial, due to the lack of supervision, it has been shown that a lot of kids are dying. So they have stopped that trial. So that I was so demoralized after seeing that trial. I thought that in that case, why in my trial it has shown so much improvement, but in this trial not. Then we are fortunate that the investigator of that trial, is very kind, and he personally communicated with me, and we had a lot of meeting, and then we have discovered that
then you
in
found
my
out
trial,
what was the missing steps.
In our trial, we had the continuously 1 hour follow-up. Every 1 hour we have the follow-up, we had the continuous monitoring. We have identified the children who develop heart failure, who develop if there is any inspiration. We identified all of those, and we had taken measures of this, and those measures they didn't have that ability to take those because of the fact that lack of continuous monitoring. So this was the thing. Then you had a systematic review, including that trial, also our trial and Ghana trial, and it has been concluded that without the physician supervision,
this cannot be applied.
Given.
I mean, no, I totally get that. And see, initial hiccups, initial challenges, and on the way in many countries, as we rightly understand, it's still being used and adopted. The adoption rate might be slow, might be a lot of hurdles, but with that persistence and what you're doing, it is really very exciting that you are able to spread this across, to countries and hospitals where the affordability rate of ventilators is lower, and especially in developing countries. And you are doing an incredible job. So kudos to you and your team. And I would say to ICDDR B, because without their support, you wouldn't have done that. And you just mentioned that right at the start of this discussion.
Certainly so.
Dr. Chisti, I need to mention a lot of medical terms based on what we have discussed, but you had kind of painted this picture so nicely for a layman, for a non-medical person like myself to understand, and I can already visualize your work. Okay, so in my mind, to lighten up a bit, and because we have reached to the end of our interview, what does Dr. Chisti do when he's not at the hospital or he's not researching on something? So tell us something fun about yourself.
Thank you very much. Actually, yes, it is true that most of my time goes here with clinical work as well as clinical research, and I used to stay beyond this life, which pass with my family, my parents, my wife, and my 3 sons in at least one day a week. I used to play cricket with them, and if not playing cricket, at least to watch cricket and football with them. And my 3 sons are very passionate about cricket and as well as football, but I also try to pass my some time also beyond the boundary of Bangladesh, as I have told I have been also working in Ethiopia with the same trial. Hopefully it is at the terminal stage where I can also tell you that with this main focusing thing, continuous monitoring, and the survival rate is enormous, almost 99% survival. So this is a very good news, which will come out very soon. And I think that my family is supporting me to go there repeatedly, although it is a very remote area compared to Bangladesh. But I love to go to the remote area to make an impact. As you know that from a study to impact, it used to take 10 to 15 years. And I want to say my thanks to all of you that all of you are supporting me to be passionate for that.
Of course. Of course. Dr. Chisti, see, you are based in Bangladesh. You are working with ICDDR B and you are a global citizen. You are going places, you are saving lives, you are working on something, a technology which has 99% accuracy. It is indeed saving lives of lot of infants who cannot afford costly medical attention. So your work is really unconventional and incredible. And that's what we do. And that's what we look for at Spill the Tea, where we can get stories like you. I'm very glad to talk to you. We have come to the end of our interview. Thank you so much. To our listeners, let us know your opinions about Dr. Chisti and his work. This podcast will be released on Spotify, Google, Apple, and all other major platforms. We will also release this on YouTube. Thank you. Nice talking to you.
It's my honor and pleasure to
Yes.
have the talk with you. Thank you.